This is a video on plant toxicology focusing on oxalates. My name is Dr. Kat Woodard, and I am going to walk you through a brief presentation on the chemistry, pharmacodynamics, pharmacokinetics, and mechanism of toxicity, as well as clinical presentation and treatment of oxalate toxicity. Oxalic acid is an organic compound found in many plants. In plants, it's usually bound to minerals forming oxalate. The terms oxalic acid and oxalate are used interchangeably. Oxalic acid and oxalates are potent chemicals that have industrial uses. Various forms of it are used as bleaches, metal cleaners, and rust removers, and in chemical synthesis and leather tanning. Either name is used for derivatives, such as salts of oxalic acid, for example, sodium oxalate, potassium oxalate, or calcium oxalate. The salts of oxalic acid differ in their solubility in water. When bound to sodium or potassium, the oxalate salt is soluble and dissolves easily in water. However, when bound to calcium, the calcium oxalate salt precipitates and forms an insoluble solid. Oxalate is found in many of the foods that we eat. Some of the foods that are high in oxalate are spinach, Swiss chard, rhubarb, beets, and nuts. Cooking these plant-based sources of oxalate will reduce the amount of oxalate that we ingest because it is partially destroyed by the heat. Oxalate is not just found in plants. There are also precursor molecules in meats and animal products. When we eat these foods, we digest the precursor molecules, which then turn into oxalate in our digestive tract. Oxalate is not essential and provides no nutritional benefit for humans. Most of the time, it circulates through our body and is excreted either in the kidneys and in the urine, or it never leaves the digestive tract. However, it can cause problems, and high levels of oxalate can cause serious harm when ingested. Recall that when the oxalate molecules bind to calcium, it forms a crystal and becomes an insoluble solid. These crystals are found in the stems, roots, and leaves of certain plants and can cause irritation and tissue damage. These needle-like crystals produce pain and swelling when they contact the lips, tongue, oral mucosa, conjunctiva, or skin. Swelling is primarily due to direct trauma from the needle-like crystals, but can also cause the release of histamine and bradykinin. The soluble form of oxalate can also cause problems. It gets absorbed through the gut and into the bloodstream, where it travels throughout the body. When oxalate travels to the kidneys, it can combine with calcium and form more insoluble crystals. When calcium oxalate crystals form, they can be detected in the urine by urinalysis or urine microscopy, like the image shown on the screen. When present in a large enough amount, these crystals grow in the kidneys and they combine with each other, essentially forming a larger kidney stone. In fact, urinary oxalate is the single strongest chemical promoter of kidney stone formation. Gram for gram, it is roughly 15 to 20 times more potent than excess urinary calcium alone. There are some differences in how individuals metabolize oxalate. Some people are more sensitive than others and are more likely to form kidney stones when they eat oxalate. For those who are prone to kidney stones, it could help to avoid foods high in oxalate. When present in high enough amounts, oxalate can cause serious harm or even death. The level of oxalate considered immediately dangerous to life or health is 500 milligrams per meter cubed. Ingestion of as little as 5 grams of oxalic acid can cause death. For comparison, this is about the weight of a single nickel. Soluble and insoluble oxalate salts are found in several species of plants. In the U.S., the majority of oxalate plant exposures occur in children younger than 5 years of age while sampling houseplants in the home. The bulbs of many flowering plants, including those of tulips, daffodils, and hyacinths, contain a high concentration of calcium oxalate. Philodendron and Diphthenerbachia exposures are among the most common plant exposures reported to poison control centers. According to the 2018 Annual Report on the American Association of Poison Control Centers National Poison Data System, 4,509 single exposures were documented for oxalate plant poisonings. Almost 3/4 of these were from children less than 6 years of age, and 1/10 were from adults. Toxicity may occur as a result of skin or eye contact, inhalation, or ingestion. The initial clinical presentation of oxalate toxicity can include keratoconjunctivitis and corneal abrasions after contact with plant material, contact dermatitis causing local skin erythema, edema, or bullae, inflammation of the oropharynx and esophagitis from ingestion, sore throat, cough, and wheezing from inhalation. Large exposures can even lead to chemical pneumonitis or laryngeal and pulmonary edema. Profound hypocalcemia can also result from ingestion of soluble oxalates, which can clinically manifest as weakness, tetany, convulsions, and cardiac arrest. Later findings include superficial necrosis, which can develop over days after initial contact. Diagnosis is based on a history of exposure and evidence of local systemic effects or oxalate crystalluria. If you are concerned about oxalate exposure, call the Poison Control Center at 800-222-1222. Here's how you would treat a patient that presents with oxalate poisoning. First, remove any plant material and treat eye and skin exposures with copious water irrigation. Always consider airway patency. Take measures to protect the airway, which may become acutely swollen and obstructed after a single ingestion or inhalations. Administer supplemental oxygen and airway adjuncts as needed. Antihistamines and analgesics can be used for patient comfort. Initial laboratory studies should include electrolytes, glucose, BUN, creatinine, calcium, EKG, and urinalysis. Continuous cardiac monitoring is recommended to recognize and treat prolonged QT interval or other arrhythmias that may result from electrolyte imbalance. Administer IV fluids and maintain high volume urine flow at 3 to 5 ml per kilogram per hour to enhance urinary excretion and help prevent calcium oxalate precipitation in the kidney tubules. Monitor the EKG and vital signs for at least 6 hours after significant exposure and admit symptomatic patients to an intensive care unit if needed. Administer 10% calcium solution, either chloride or gluconate, to counteract symptomatic hypocalcemia and treat seizures and arrhythmias if they occur. As with all poisonings, prevention is the best way to avoid serious injury. Thank you for watching, and I hope you have enjoyed this video on oxalate toxicity.